ഉണ്ടോ? വിസിബിൾ ആണോ?
അല്ല സർ, വിസിബിൾ അല്ല. സാറിനെ കാണുന്നത്.
ആണോ? ശരി. ഇപ്പോഴോ? ഇപ്പൊ കാണുന്നുണ്ടോ?
കാണുന്നുണ്ട് സർ, കാണുന്നുണ്ട്.
ഓക്കെ ഓക്കെ ശരി.
ഓക്കെ. ഐശ്വര്യ, ബാക്കിയുള്ളവരൊക്കെ മ്യൂട്ട് ചെയ്യൂ. ഐശ്വര്യ, സാറിനെ ഒഴിച്ച് ബാക്കിയുള്ളവരൊക്കെ മ്യൂട്ട് ചെയ്യണേ. ഓക്കെ സർ. കുട്ടികൾക്ക് ഞാൻ ജോയിൻ ചെയ്തുകൊണ്ട് ഇരിക്കുന്നേ ഉള്ളൂ സർ. നമുക്ക് കറക്റ്റ് ആയിട്ട് തുടങ്ങാം. നമ്മൾ സാധാരണ കറക്റ്റ് ആയിട്ട് തുടങ്ങുന്നത് ബിക്കോസ് സിൻസ് ദിസ് ഇസ് റെക്കോർഡഡ് ആൻഡ് വി സ്റ്റാർട്ട് അറ്റ് 7 o'clock itself. സോ നമ്മുടെ സർജറി ക്ലാസ് സർ ഇതിനു മുമ്പും എടുത്തിട്ടുള്ളതാണ് നമുക്ക്. സോ ഇറ്റ്സ് വെരി ഡിഫിക്കൽട്ട് ടു കവർ സർജറി ഇൻ ഈ പറഞ്ഞ പോലെ 2-3 ക്ലാസ്സിലൊന്നും നമുക്ക് കവർ ചെയ്യാൻ പറ്റുന്ന കാര്യമല്ല, എല്ലാവർക്കും അറിയാം. ബട്ട് സ്റ്റിൽ നമുക്ക് ഇതിനകത്തുള്ളൊരു ഐഡിയ കിട്ടാൻ വേണ്ടിയിട്ടും സാറിന്റെ ക്ലാസ്സസ് വെരി മച്ച് സോട്ട് ആഫ്റ്റർ. കഴിഞ്ഞ പ്രാവശ്യം കുട്ടികൾ വീണ്ടും ദേ യൂസ് ടു സീ ദിസ് ക്ലാസ്സസ് റെക്കോർഡിങ്സ്. എക്സാം വരെ അവർക്ക് അത് ഡ്രൈവിൽ അവർ കാണുമായിരുന്നു. അപ്പം വി ഹാഡ് ഗോട്ട് വെരി ഗുഡ് റിവ്യൂസ് അബൌട്ട് സർസ് ക്ലാസ്. സർ ഇസ് വെരി കൈൻഡ് ഇനഫ് ടു ടേക്ക് ക്ലാസ് ഫോർ us again. സോ സർ ഇസ് കറന്റ്ലി വർക്കിംഗ് അറ്റ് ഗവൺമെന്റ് മെഡിക്കൽ കോളേജ് കോന്നി. സോ ഒരുപാട് ബുദ്ധിമുട്ടുകളുടെ ഇടയിലും തിരക്കിന്റെ ഇടയിലുമാണ് സർ ക്ലാസ് എടുക്കാൻ വന്നിരിക്കുന്നത്. സോ ഐ എം എക്സ്ട്രീംലി ഗ്രേറ്റ്ഫുൾ ടു യു സർ ഓൺ ബിഹാഫ് ഓഫ് IMA, KSB ആൻഡ് ഓൾസോ പേഴ്സണലി ഓൾസോ. സർ, അപ്പോൾ ഇന്നത്തെ ക്ലാസ് നമുക്ക് അധികം താമസിക്കാൻ തുടങ്ങാം. ബാക്കി കുട്ടികൾ ജോയിൻ ചെയ്യുന്ന മുറയ്ക്ക് ജോയിൻ ചെയ്യും. സോ സർ വിൽ ബി ഹാവിംഗ് an interactive session. So thank you sir. Over to you sir.
Okay, so thank you Sapna for those kind words. So good evening to all. I presume I am audible and as well as visible also. Okay, so we had already discussed
കേൾക്കുന്നുണ്ട് സർ.
Yes. So we have already discussed the main topics of general surgery in various sessions. Now, what I am planning is we will have 2 sessions for general surgery. So we will basically discuss most of the what can you say, the topics or the questions which are likely to be confusing. I'm not going to focus on recall questions. As you know, for multiple choice questions, you will have recall type of questions where your rote memory is tested. Say, for example, this sign, arousing sign is seen in which condition. That's example of a recall type where your memory alone is tested. Whereas if you look at the current NEET pattern, it mainly focuses on application type question. Like they will give you a scenario and they will ask you to answer questions based on the scenario. So it is basically an application testing of how much you are aware of how a situation can be handled. So I have mostly included those sort of scenarios as well as clinically based questions. Okay, so as towards the end of this class, we can discuss and decide whether we should have a similar session for our next session also, or you want to have a different approach. Okay, so do you know what these numbers stand for? 73,000, 4,300. Okay, it is nothing related to general surgery. What it only highlights is the number of postgraduate seats which are distributed across our country and the states. Roughly, you have around 73,000 postgraduate seats. Okay, among which around 4,300 is for general surgery, MS general surgery alone, the department where I am working for. Okay, and the last two are the numbers from Kerala. We have around 1,100 seats in the government setup in Kerala and around 900 seats in the private setup. What it means is that each one of you who is watching this video or this live session has got a very high chance of getting into one of the postgraduate seats. Okay, yes. So, okay, I do sincerely hope that each one of you pass through flying colors and get into one of these seats, the seat which you want and you would shine through in your career. Okay, so how has the need been evolving? If you look at the previous trends at general surgery, now the focus is mostly on clinical scenarios as well as image based questions. Previously, there was more focus given for recall type questions, which I told you earlier, right? So this sign is seen in, and which is the first branch of etc. etc. those type of questions are basically testing your recall memory, whereas now the focus is on clinical scenarios. There will be a short description of a condition, or an image will be given with a very short stem for the condition, and you are asked to give answers based on that. So what does that mean? There is no point in mugging up. Okay, there is no point in just learning that this much percentage of conditions are caused by this bacteria, etc. You have to know the subject, means you must have seen patients, you must have analyzed questions based on that pattern. Okay, so when you get a clinical scenario, so when you practice clinical scenarios, you have to focus on the diagnosis, you have to focus on the main investigations as well as the management. Because if you get the diagnosis wrong, then obviously the investigation you cannot choose the correct one, and subsequently you won't be able to select the correct management also. So always when you practice clinical scenarios, practice about how to diagnose a condition based on the description given. Usually on the question itself there will be a pointer, so that we will see as we see the questions. Okay, so you will have a pointer as to how you can diagnose a condition. So, what are the key topics? Based on the previous year's questions, these are supposed to be the key topics. Obviously, now the time is very limited. You have about, I think, less than 2 months' time to prepare for the NEET. So, you won't have time to read through the entire Bailey and Love or whichever text you are following. So the topics from which large number of questions have been coming over the past few years include trauma. Because trauma is very common, the clinical condition is very common, large number of questions have been coming from trauma. Then gastrointestinal surgery, breast surgery, and broadly oncology. These are the topics for which there is a high weightage, means you get a large number of questions from these topics. And the conditions include, one is appendicitis, because this condition is very common clinically. You get questions from appendicitis, all types of hernias, most commonly inguinal and femoral, then gallstones, breast cancer, and all sorts of thyroid disorders. Because these are pretty common conditions when you take our scenario, the Indian scenario. Hence, the focus on these conditions. So, the various aspects would include how they would present, how you would diagnose, and how you would treat. Then surgical emergencies, including acute abdomen, acute scrotum. Okay, then perforation of bowel, obstruction of bowel, mesenteric ischemia. Then some questions do come from some, you can call them as relatively dry areas or dry topics, that is fluid electrolyte management. It's a bit dry, not very easy to apply clinically, but then questions do come from there because they form the basis for your clinical practice. When you get into clinical practice, whether you are a physician or a surgeon or an intensivist or whatever, any clinical side you choose, you have to have a strong base of how the fluid and electrolytes are managed. Hence, questions do come from them, and specifically, the situation might be related to conditions where fluid electrolyte management is very important, like burns, pancreatitis, etc. Then various trauma protocols, like the ATLS guidelines. ATL guidelines tell you how to manage trauma. Then related trauma conditions like compartment syndrome, which are important clinically. Then, of course, emergencies which occur along with malignancies like bleeding or obstruction of bowel. And lastly, when you do surgery, you do get complications. So, questions related to anastomotic leakage, deep vein thrombosis. So, all if you look at all this, these are relatively common conditions. That is why so much of questions do come from these areas. So, okay, let's go into the questions. As we discuss the questions, if you have any doubt, please feel free to ask if you are able to unmute. Okay. Or else, if you are not able to, at the end of the session, you can give your questions orally or you can put up the questions on the chat. I will try to answer it today or during the next session also. Okay, so when you get a question, I'm not going to ask you to discuss because it will take a lot of time, especially because we only have two sessions. It is not practical to to ask each one of you to answer, or ask you for the answers. I will give you the answers, but when you see the question, at least try to think. Imagine that you are sitting in the examination hall. As soon as you get the question, you try to find out what is the answer. Okay, so that's a practice for you. In fact, if you look at how you are supposed to practice, now for the next 2 months, one practical advice would be you do the previous year's questions, and that too not in a leisurely manner. Time yourself. Okay, so for NEET, you have so many hours to cover so many questions. Like that, you keep a timer in your mobile or alarm clock, and then you try answering the questions within that time, so that you get into the habit of quickly answering questions. Because your university questions, you have more of time. Also, it's descriptive. You can write your answers at your own pace. Whereas for NEET, because it is multiple choice questions based, you have to be able to quickly read the question, and also read the question in such a manner that you don't miss the key points. Sometimes there will be a key pointer there, which is the clue to the answer. If you miss that key pointer, you might lose your answer. Okay, so read the question properly but quickly, and then try to find out the answer. So your focus should be on that, as well as being able to answer within a time bound manner. Okay, so let's see. Yes. So there is a 45 years old male who is presenting with sudden onset severe epigastric pain radiating to the back. Serum amylase is 1200 units per liter. What is the appropriate initial management? So this is a clinical scenario based question. It's a male with severe epigastric pain radiating to the back. So, along with that, we have a serum amylase which is more than 1200. The normal values for amylase are any values which is between about the lab difference is there, but it is less than 100. This is obviously 10 times more than the normal value. So this is obviously a case of pancreatitis, acute pancreatitis. So the clue here is the epigastric pain radiating to the back, and the 10 times increase in amylase. Pancreatitis is diagnosed when two out of three conditions are met. One is the typical pain, which is epigastric radiating to the back. Second is increase in amylase or lipase of more than three times the normal value. And third is the imaging findings. If two out of these three are positive, we call that as acute pancreatitis. So, what is the most appropriate initial management of acute pancreatitis? Is it intervention, that is ERCP, endoscopic retrograde cholangiopancreatography? Is it IV antibiotics, or is it aggressive fluid resuscitation? Or lastly, whether you want to keep the patient nil by mouth. So the confusion here might be whether you want to go for intervention or nil by mouth or fluid resuscitation. See, ERCP is not done in the acute phase. It can treat pancreatitis, but it is not in the acute phase. Also, antibiotics are not an essential component. You can give them if you detect any infected pancreatic necrosis. The most important management is aggressive fluid resuscitation. See, pancreatitis is a condition when there is large amount of fluid being lost in the third space, in the peritoneal cavity. So the patient is going to go into hypotension. So the most important is aggressive fluid resuscitation. What about nil mouth? Do you need to keep patient nil by mouth? Actually, the recommendations are not for nil by mouth. It's like your orogastric feeding is not recommended in severe pancreatitis, because if you give food into the stomach, it can go into the duodenum. It might irritate the pancreas more, causing pancreas to secrete more enzymes, which can damage the pancreas itself. See, pancreatitis is a condition where you have auto damage to the pancreas. So, hence, the preferred method of feeding is nasojejunal feeding. Okay, and for mild pancreatitis, you need not even keep the patient nil by mouth. Patient can very well take light feeds orally. Okay, so the treatment is by aggressive fluid resuscitation to prevent hypovolemic shock. One complication of pancreatitis is it can cause organ failure, which is a sequelae of hypovolemia. Okay, so which is a late sign. So always, as I told you, look at the question completely before you click. Which is a late sign of compartment syndrome? Compartment syndrome means a patient who gets increased compartmental pressure. You have various compartments in the body: the forearm compartment, thigh compartment. it is usually seen in the limbs. So, which is a late sign of compartment syndrome? Is it pain on stretching, or pallor, paresthesia, or pulselessness? All these are features of compartment syndrome. But if you look at these, pain which can occur very early. Okay, if there is any stretching of the capsule, stretching of the nerves, stretching of the muscle fascia, you do get pain early. Pallor you can get sometimes, but not always. If it's a fracture, you can get. Fracture is one of the causes for compartment syndrome. What about paresthesia? Again, if your nerves are involved in the compartment, they can undergo pressure and they might give a feeling of paresthesia. Pulselessness, artery is not that easy to compress. Okay, so pulselessness will occur only in the later stages when the artery is compressed by too much of compartmental pressure. Okay, so the classical findings include pain, severe pain, pain on passive movement, that is the pain, pallor, paresthesia, paralysis. Last one is pulselessness. A 50 years old patient with a history of weight loss and iron deficiency anemia. What is the first investigation of choice? Is it bone marrow, endoscopy, CT, or barium swallow? Okay, obviously you know that you do need a bone marrow in iron deficiency anemia, but there is a history of weight loss here. Okay, so there is some GI pathology. Do you go for a barium solo? Solo is not at all recommended condition now. It has been superseded by CT. CT is very well easily available and also much more efficacious diagnostic point of view. Is it CT or endoscopy? See, weight loss and iron deficiency anemia means there are two possibilities. There is probably a malignancy, one of the most common causes for a 50 years old male with weight loss and iron deficiency anemia is a carcinoma of the stomach or the colon. So it's some sort of endoscopy. And stomach cancers are much more commoner than colonic cancers to produce iron deficiency anemia. So the obvious choice here is an upper GI endoscopy. Okay, because you are worried about gastric cancer, the definite investigation is, of course, that you cannot delay the upper GI endoscopy. Okay, why a endoscopy? Because you can visualize the tumor. CT is good, but then CT is not good enough for luminal conditions. CT is good for surface conditions. If you have a gastrointestinal stromal tumor, something which grows out from the wall, CT is very good. But early lesions of cancers, which are visible only as mucosal irregularities, are best visualized through endoscopy. Endoscopy means you are putting the scope, seeing the tumor, taking a biopsy, seeing the bleeding, etc. Okay, so which is the fluid which is contraindicated in major burns during the first 24 hours? Is it dextrose, colloids, Hartmann solution, or normal saline? A, B, D are examples of crystalloids. So you would know that fluids are divided into crystalloids and colloids. Colloids are those one which are heavy. In common terms, you can say that these are heavy, okay, heavy liquids. Whereas crystalloids are the one which are the light ones, which are usually hypo or isotonic. So Hartmann solution, dextrose water, dextrose is otherwise called as dextrose water. Then normal saline, all these are crystalloids. Colloids are not used in the initial 24 hours in patients with any sort of fluid loss because they will increase the capillary leakage and worsen the edema. You want the fluid to stay inside the intravascular compartment. That cannot be done with the colloids. Okay, so crystalloids are the preferred solutions. So the answer here is colloids. Okay, and specifically sometimes you may get questions on Hartmann solution. It is also called as Ringer's lactate. The names are used interchangeably. Hartmann's contains basically sodium chloride, potassium chloride, calcium chloride, and sodium lactate. Okay, that's why the name it is given as Ringer's lactate. It is used to treat acidosis, etc., etc. Okay, yes. So, which of the following is the gold standard investigation for diagnosing acute appendicitis? So, the question is gold standard. Gold standard means some investigation which is the investigation of choice. If you have all the options available, gold standard means you would go only for that. Okay, that is the best investigation. You have X ray, CT, ultrasound, and MRI. X-ray in appendicitis is not very useful. You might see some fat lines and all, but not very useful. What about CT? It is good. What about ultrasound? Ultrasound is good, but not as good as a CT. Okay, if you don't have a CT available, you might go for an ultrasound. But if you have both facilities available, the investigation of choice is CT. MRI is an overkill. You don't need MRI. Okay, it may be done in pregnant patients. Supposing there is a pregnant patient and your ultrasound is the initial investigation and you want to confirm, then you might, if your ultrasound is not diagnostic enough, then you might go for an MRI because the patient is pregnant and cannot be exposed to ionizing radiation. The investigation in all other patients is a CT scan because it the higher sensitivity as well as specificity. Okay, so sensitivity means you are not going to miss any positive patients. Okay, and specificity means you are not going to pick up any negative patients. Okay, so that is the concept. There is a young male who is presenting with swollen, painful scrotum and associated vomiting. What is the most likely diagnosis? So the point is, it's an acute scrotum. It is painful as well as swollen. So the most common conditions which can produce acute scrotum include torsion or acute epididyma orchitis. Both can produce. Hydrocele, varicocele are chronic conditions. They are not likely to produce acute scrotum. But here the catch is the omitting. Omitting is usually a feature associated with torsion. Okay, testicular torsion. Why? Because your testis is developing inside the abdomen and later it descends into the scrotum as during the uh, nearer closer to delivery. So testicular pathologies might be having abdominal complaints also like nausea and vomiting. Okay, so the diagnosis is torsion. If it is epididymitis, you might have a painful swollen scrotum but usually without vomiting. Okay, so, what is the primary goal in the initial management of a patient with severe head injury? Is it adequate pain control or maintaining cerebral perfusion pressure or an early surgical intervention or a rapid imaging? See, pain control is of course important. Then imaging to know what is the condition also is important, and intervention also might be important if it warrants intervention. But what is mostly important is maintenance of cerebral perfusion pressure. Okay, because there is a doctrine that is Monroe Kelly doctrine. What does it say? You have the skull cavity is a closed cavity. It cannot expand. It can accommodate a fixed volume of brain tissue, and the rest is taken up by CSF and blood. See, you have a tumor. Okay, you have a bleed here. Instead of tumor, you have a bleed. What happens? The brain tissue expands. So, what will happen to CSF or blood? These will be driven out. That means either the CSF will come out as CSF autoria, rhinorrhea, etc., or the blood will be driven out, means the blood will be pushed out of the brain. That means the cerebral perfusion will reduce. So, if the intracranial pressure increases, that is called the Monroe-Kelly doctrine. Okay, if the intracranial pressure raises, then the cerebral perfusion pressure will fall. So you want to maintain the cerebral perfusion because at any point, if continuously the cerebral perfusion is reduced, that can damage the cerebral tissue. See, the patient is having an acute brain hemorrhage due to say trauma, so you are not sufficiently maintaining the cerebral perfusion, means see after one day you go for surgery, you do evacuate the hematoma and all, but during that 24 hours if you have not maintained the cerebral perfusion, the brain tissue, it is the neural tissue is one of the most, what can you say, picky and tricky tissues in the body. It cannot withstand ischemia, it cannot withstand hypoxia, etc. So beyond 24 hours, the neural tissue will have undergone irreversible damage. The patient will have all sorts of sequelae. There will be focal neurologic deficit. The patient might have cognitive impairment, memory impairment, etc. So the most important is to maintain cerebral perfusion pressure to prevent what is called as a secondary brain damage. See, primary brain damage has already occurred. Your road traffic accident, your fall has given the primary brain damage. What you're going to prevent is a secondary brain damage by preventing hypoxia, by preventing hypotension, etc. Okay, yes. So a patient with a history of peptic ulcer presenting with acute onset severe abdomen pain, and there is a palpable mass in the epigastrium, which is the most likely diagnosis. Is it a cancer, a cyst, a gastrointestinal stromal tumor, perforated ulcer, or chronic volvulus. See, among these, chronic volvulus is very, very rare. You are not going to get it very commonly. Gist and cancer are rare, but here the catch is there is a history of peptic ulcer with acute onset severe pain. Whether it is gist or cancer, they will not present usually with acute onset pain. It will be a chronic onset pain. Okay, will you, so the question is, will you get a mass in perforated ulcer? Yes. Sometimes if it's a perforated ulcer and if the patient presents late, what will happen is the body will try to localize the peritonitis by plugging it with the omentum. So the omentum might be plugging there, producing a feeling of a mass. It might be the inflamed stomach with the omentum. Hence, this is most probably a perforated peptic ulcer, and gastric cancer or gist are very, very less common possible diagnosis. What is the most common cause of intestinal obstruction in adults? Is it hernias, adhesions, tumors, or volvulus? We have only talked about intestinal. So the most common intestine means the biggest amount of intestine is, or the largest volume of intestine is taken up by the small bowel. Small bowel is more than 6 feet, whereas you have the around 1 meter of large bowel. Okay, so small bowel obstruction is most commonly caused by adhesions. Hernias can cause obstruction, tumors can cause obstruction, but that is more commonly seen in the large bowel or the colon. Volvulus also is more commonly or very, very rarely only seen in the small bowel. Small bowel obstruction caused by post-operative adhesions. Again, it is due to post-operative. The condition which causes adhesions commonly is usually laparotomy. You do a laparotomy and the patient will have small bowel coming and sticking onto the cut ends of the peritoneum or the inflamed peritoneum, producing adhesions. It's very, very common. Laparotomy producing adhesive intestinal obstruction. Okay. So the patient presenting with a history of breast cancer surgery, is breast cancer surgery now presenting with a swelling of the arm on the same side. What is the most likely diagnosis? Is it DVT, cellulitis, lymphedema, or just you have an option that is lipoma? Okay, so here the catch is the breast cancer surgery. If it was only breast cancer, it could be lymphedema or DVT, whereas the patient has already undergone surgery. That means probably it was a mastectomy, wherein you would also tackle the axilla and do an axillary dissection. And the most common complication, or one of the most common complications after an axillary dissection, is an lymphatic edema. Okay, so when you remove all the axillary lymph nodes, sometimes if your lymph node dissection is so meticulous and there are no collateral forming to drain the lymph, it can cause lymphedema, chronic lymphedema. So the patient will have chronic arm edema. Later, it might even turn into something like an elephantiasis. Okay, so you have the filarial leg, that is elephantiasis, where you have chronic lymphedema producing all the complications of edema, thickening, fibrosis, nodule formation, even ulceration, etc. Okay, so this is caused by lymphedema. And one very dangerous complication of post mastectomy lymphedema is lymphangiosarcoma. If this lymphedema is persisting and you are not able to treat it, it might even go into a lymphangiosarcoma, which is given the name as Stewart-Treves syndrome. Okay, that's a late complication. So for acute cholecystitis, what is the optimal? So the question here is optimal. See, this question, if you look at, say, question papers around 4 to 5 years back, you would get a different answer. Whereas currently, you have a very specific answer. The optimal treatment for acute cholecystitis is it by giving antibiotics, or you want to do an ERCP, or you want to drain the GB by doing a percutaneous cholecystostomy? And now please be very sure that the treatment now is cholecystectomy. In acute cholecystitis, the best results are obtained by emergency cholecystectomy. That means in the during the admission time itself, it is best that you remove the gallbladder. Okay, you can give, of course, antibiotics. You only thing is, if you go in and if you see that the gallbladder is severely inflamed and adhered to surrounding tissues, sometimes you might come out by doing a cholecystostomy, but that is done in very limited number of patients. Cystostomy means you put in a tube, a Foley's catheter or a Malacot catheter into the gallbladder and allow the pus to drain outside. Okay, that is for an empyema of the gallbladder. Whereas for acute cholecystitis, the definite treatment now is cholecystectomy. Okay, a patient with a history of smoking presenting with painful pulsatile mass in the abdomen. What is the most likely diagnosis? There should be no confusion. It is abdominal aortic aneurysm. See, aneurysms or vascular aneurysms are very common in patients who are smokers. So you have a very specific features here. It is pulsatile, so it's an aneurysm. Lower abdomen means it cannot be anything else. This abdominal aortic aneurysm is one of the commonest sites for aneurysm. It is abdominal aortic aneurysm. Okay, so how do you treat this? Basically, abdominal aortic aneurysms, small ones. Once you do the CT or CT angiography, small ones, that is usually about less than 6 centimeters, you can observe and follow up because they are unlikely to produce complications like a rupture. That is more than 6 centimeters. It is definitely indicated to go for surgery and then treat the aneurysm so that it won't rupture and produce a catastrophic event. Okay, so what is the best initial? Here the catch is the initial. The best initial imaging modality for suspected acute appendicitis in a pregnant woman. See, in the non-pregnant, we told it is CT. So pregnancy, obviously, CT is ruled out. So the question also X-ray is not recommended because it also has got ionizing radiation. Question is, would you go for ultrasound or MRI? So here the catch is the initial. If there is no initial, if the question was the best modality to diagnose acute appendicitis in pregnancy would be MRI. But because the question is initial, the answer is ultrasound. Okay, because it is safe, effective, but also you can do it as the first step. If your ultrasound as the initial investigation is conclusive enough, there is no need to go for MRI. If there is clinically or sonologically confusion only, you need to go for the definitive, that is the MRI. A patient with history of chronic liver disease presenting with jaundice and ascites. So chronic liver disease causing jaundice, ascites. What is the most likely cause? So what is the complication of chronic liver disease which is causing the ascites? Is it portal hypertension, hepatic artery thrombosis, peritoneal carcinomatosis, or tuberculous peritonitis? Of course, as others are very, very less possible. The obvious answer here is portal hypertension. See, hepatic venous thrombosis can occur in portal hypertension. The name given for that is the Budd-Chiari syndrome. So one of the causes for portal hypertension. Peritoneal carcinomatosis does not arise in chronic liver disease. Okay, so chronic liver disease usually will lead to hepatocellular carcinoma or hepatoma only. So why do you get portal hypertension? So portal hypertension, because the cirrhosis is there, all the liver nodules are stricturous, they have become cirrhotic and nodular, which leads to increased portal venous pressure. Ascites occurs because of the imbalance in the hemodynamics and oncotic pressure, means the portal venous blood cannot enter the hepatic sinusoids because of the increased portal pressure. So that oozes out into the peritoneal cavity. Whereas jaundice can be due to two reasons. One, bilirubin is synthesized in the liver. If the liver function is affected, in late stages of liver disease, you have impairment of the synthesizing functions also. So bilirubin is only less, there is abnormality in the production of the bilirubin, or there could be an obstruction. Whatever bile you have, which is secreted into the bile duct, is not being secreted into the bowel because of the obstruction caused by the portal hypertension. Because of the increased portal pressure, all the bile is not freely flowing into the bowel. That is the reason for the jaundice. Okay, so you have the exact reasons being mentioned here. Okay, portal hypertension, fluid accumulating because of the increased pressure in the portal vein. And the one diagnostic, sometimes this can be a question, an MCQ. The role of SAG or serum ascites albumin gradient. You measure the serum albumin, you measure the acetic albumin. Any value more than 1.1 means it is probably a transudative ascites. You have the transudative and exudative. Transudative is commonly caused by ascites, then heart failure, etc. Whereas exudative is caused by other conditions like malignancies, etc. Okay, yes. So, what is the commonest cause for acute appendicitis? Is it obstruction? Is it infection? Is it inflammation or torsion? See, appendicular torsion is not at all common. Inflammation of the mesentery is not that common. The two main types of appendicitis are with it could be obstructive or it could be catarrhal. Catarrhal means there is inflammation, or you can say there is a mucosal irritation of the appendix. The common cause is usually obstruction. That too commonly caused by fecolith. Fecolith means the all your fecal matter sometimes can become inspissated and become turn into a stone-like substance. So this can enter into the appendicular lumen, so that can produce obstruction to the your appendix is a structure which has got mucosal cells. It is continuously secreting mucus. So if the mucus is obstructed by the fecolith, it can produce an obstructive type of appendicitis. The other cause is lymphoid hyperplasia occurring in the base of the appendix also. The commonest cause is usually a fecolith. So, which is an early and common complication of thyroid surgery? Is it reduced calcium, increased calcium, increased thyroid levels, or decreased thyroid levels? So, obviously, you would get reduced thyroid hormones, but it is not an early complication. So, your thyroid hormone has got a half life of around 3 weeks. If you do a thyroidectomy today, the patient might get hypothyroidism after 3 or 4 weeks. Okay, not in the immediate stage. Hyperthyroidism can occur in one very specific situation, that is thyroid storm. If the patient is in a toxic state and you are taking up the patient for surgery without controlling the toxicity, when you handle the gland, all the hormones could be released in the circulation, producing what is called as thyroid storm. That is hyperthyroidism, but that also is not very common. Okay. Instead, what you get is hypocalcemia. There is not because of thyroid gland, but because of parathyroid glands. You have four parathyroid glands, two superior, two inferior, which are located very close to thyroid gland itself. So when you do surgery, one, you might accidentally remove the parathyroids because they are very small. Sometimes you might mistake them for fat or small lymph nodes. Other much more common condition is when you ligate the inferior thyroid artery, because the inferior thyroid artery mostly supplies the parathyroids. So if you have to dissect and remove the gland, you will have to remove the ligate the inferior thyroid artery. So when you do that, the parathyroids might become devascularized. That is one of the commonest mechanism by which you get early hypocalcemia after a thyroidectomy. What is the most common type of breast cancer? Is it ductal in situ, lobular in situ, or invasive ductal, or the other types like medullary? It is invasive ductal carcinoma. Okay, so you have to know that the majority, that is 70 to 80 percentage of breast cancers are invasive ductal cancers. Lobular carcinomas are form about only about 10 percentage. Okay, what about in situ? In situ is there, but it is even less detected as compared to invasive ductal cancers. Okay, medullary are all much rare. You have other types like the tubular, medullary, mucinous. All these form around less than 10 percentage only together. Okay, so the majority is invasive ductal carcinoma, and there is a specific pathologic subtype which is the commonest one. It is called as no special type or not otherwise specified. So the full answer would be the commonest type of breast cancer pathologically is invasive ductal cancer, not otherwise specified. IDCNOS or NST, no special type. IDCNST. All the special types, including the medullary, tubular, all are very rare. Okay, and interestingly, the common one also has got the worst prognosis also. So IDC NOS has got the worst prognosis as compared to medullary etc., lobular etc. Okay, yes. And one interesting thing you should can know is that, see, a patient has got DCIS, ductal carcinoma in situ in the left breast. That means this patient has got a higher likelihood of developing cancer in the same breast. Left DCIS means this patient is likely to develop invasive cancer in the left breast. So you should treat the DCIS by doing a lumpectomy or giving radiation or giving a chemoprophylaxis. There is another patient who is having lobular carcinoma in situ in the left breast. So lobular carcinoma in situ is not a pre-malignant condition. It's only a predictor of cancer. That is different. Okay. So DCIS left breast means cancer going to occur in the left breast. Lobular carcinoma in situ in the left breast means the patient might has got higher chance of developing breast cancer, but equally on both sides. It could be on the left or right. Okay, so it need not be occurring on the same side. So hence, for that logic, for a patient with LCIS, you will not do a lumpectomy or you will not do a surgery. Okay, you might give a chemoprophylaxis, you might give tamoxifen or hormonal prophylaxis, but you will not do a surgery on the ipsilateral breast because the risk is equal for both sides. Okay, what is the primary treatment for a strangulated hernia? So, hernia, as you know, can first become irreducible, later it will become obstructed, where the luminal contents are blocked. Okay, they are not allowed to pass through. And last, you get strangulation, which means the blood supply is cut off. It is going to become gangrenous. What is the management? There is no conservative management here. You don't, trust is not at all recommended for any hernia. Elective surgery, you can't wait because the patient has already gone into strangulation. Here, the treatment is immediate or emergency surgery because if you wait, what is going to happen? The bowel is going to become necrosed. Necrotic bowel means it can perforate, which means it can lead on to peritonitis. Which is a characteristic of a basal cell carcinoma? Is it highly aggressive and metastatic, or is it locally invasive but rarely metastasis, benign, or found in internal organs? Of this, the characteristic of BCC is it is locally invasive. It is otherwise called as rodent ulcer. Rodent means something like your rat, which eats through things, right? If you give a cheese, if you see the Tom and Jerry, you will see Jerry always biting at the cheese slices like that. So the BCC will eat through the skin and subcutaneous tissue, but it will rarely metastase. It is not aggressive compared to a squamous cell or melanoma. Melanoma can be seen in internal organs like the liver, like the choroid of the retina of the eye, etc. Squamous cell carcinoma can also occur in mucosal linings. See, stomach cancer can be a squamous cell carcinoma sometimes, then esophagus, etc. Okay, so internal linings you can get squamous cell carcinoma, whereas BCC is never internal, it is always cutaneous, it is locally invasive but does not metastase. Okay, which is the most common cause for acute cholecystitis? Is it gallstone, infection, hepatitis, or pancreatitis? It is gallstones. Okay, gallstones are the most common causes for cholecystitis. How? You have gallstones. Gallstones might obstruct the cystic duct. So all the bile, all the mucus will be obstructed inside, producing inflammation and then infection. Secondarily, you get infection. Primarily, it is inflammation. That is why gallstones cause acute cholecystitis. Which is a common indication for tracheostomy? Is it upper airway infection, like some, or is it COPD, prolonged mechanical ventilation, or sinusitis? Obviously, you won't do tracheostomy for a sinusitis. Okay, so here the answer is prolonged mechanical ventilation. If a patient is on prolonged mechanical ventilation, in order to reduce the work of breathing and to prevent the complications of, supposing the patient, if the patient was, see, had during the COVID times, many patients were ventilator dependent. So if you put the patient on ventilator for long periods, what will happen? The endotracheal tube, it will cause tracheal mucosal necrosis, producing tracheoesophageal fistula, stenosis, etc. All sorts of complications. Whereas tracheostomy will prevent those. You can take out the endotracheal tube. Tracheostomy is much more easier to manage, and you can maintain this on for long term. Okay, so tracheostomy might there are many patients who live their normal lives with a tracheostomy in situ. Okay, that is, we just need to take care of it. That is the commonest indication. Very rarely for severe acute upper respiratory infections like severe epiglottitis, you might need a tracheostomy also. Okay, yes. Which is the most common site of a vascular aneurysm? Is it the aorta, the carotids, femorals, or the popliteals? It is aorta. You do have aneurysms occurring in the carotid, femoral. Popliteals are relatively common. Then inside the brain, you have the berry aneurysms also common, but the most common is abdominal aortic aneurysm. What is the primary function of the adrenal glands? You know, the adrenal glands has got a role in secreting of the sex hormones, that is androgens. It also secretes, the adrenaline, corticosteroids. It does control various electrolyte levels. But the most important among all these roles, the most important is the production of adrenaline and cortisol. Because for maintaining the normal body pressure, normal body metabolism, you do need these two hormones. That is the mineralocorticoids, the and the uh, from the medulla you have the epinephrine and the norepinephrine, and also from the cortex you have the cortisol. That is the most important function of the adrenal glands. Even when you do a bilateral adrenalectomy, you would mandatorily have to replace first cortisol. That is, glucocorticoids are the one which are first or most importantly need to be replaced. The others, the body might produce in small amounts from some other sites, but you will have to mandatorily replace the corticosteroids. That is the most important function. Okay, which of the following is a suture material? Cotton, silk, stainless steel. You might be tempted to answer for silk alone, but we have to know that cotton was, say, it is not commonly used nowadays. Naturally occurring cotton was one of the commonest suture materials which was prevalent, say, around 2-3 decades back. Silk, from the silkworm. Then stainless steel also is used for closing bones. See, after your open thoracotomy for a coronary artery bypass graft, you would close the sternum with stainless steel sutures. The other naturally occurring material would be catgut. Catgut, which is obtained from the bowel of sheep. Okay. Yes. So this is, you can say it is a tricky question, because which of the following is the most common cause of acute pancreatitis? See, practically, if you have sat in the casualty, if you have sat in the wards, you would obviously know that alcohol is the common cause, at least in our setup. In the Indian setup, alcohol is the common cause. But the problem is that textbook wise, it is not alcohol but gallstones, because textbooks mostly quote from Western data. So, because the acute alcoholic pancreatitis is not common in the Western setup, due to their, it's something like an evolutionary phenomenon. The Western population, they are more accustomed to having moderate amounts of alcohol without developing much of complications. Even when they develop complications, it is mostly malignancies rather than pancreatitis. Whereas in our setup, we mostly get patients after every celebration, like any festival, they present to casualty with alcohol induced acute pancreatitis. Of course, trauma can cause, of course, hypertriglyceridemia can cause, but as per textbook reference, the commonest cause for acute pancreatitis is gallstones. Keep that in mind. Okay. Yes. Which is the most common site for colorectal cancer? Among the colonic sites, it is the rectosigmoid which is the most common. There is slight confusion regarding whether it is rectum or sigmoid. It is mostly caused because sometimes there is no distinct anatomical separation between rectum and sigmoid. Sometimes when a colonoscopy is done, rectum might be confused as sigmoid and vice versa. Having said that, most books do say quote sigmoid as the most common site. So if we have a choice between sigmoid and rectum, it is safer to choose sigmoid. Okay, because see, the national board asks various experts to give questions. They have a question bank, and the expert also gives the keys. Mostly it is from standard textbooks, including Bailey or Sebastian and all. So the mostly accepted answer is sigmoid. The second common is rectum. So if you don't have sigmoid, straight away go for rectum. If you have sigmoid and rectum, it is safer to go for sigmoid. Which of the following is the most common type of thyroid cancer? Obviously, it is papillary carcinoma. I put this question mainly to discuss because he's supposing there is a question. A patient with a long-standing history of goiter has now developed a malignancy. What is most likely to be? Then your answer should be follicular carcinoma. Okay, follicular is more likely to develop in long-standing goiters, whereas papillary usually develops as solitary nodules in what can you say, it doesn't develop from pre-existing goiters. Okay, it develops by itself. Medullary is not that common. Anaplastic is still more uncommon. Papillary is the common, especially if the patient is a young, especially if the patient is a female. Okay, which of the following is the most common cause of upper GI bleeding? Is it variceal bleed, peptic ulcer, Mallory-Weiss? Mallory-Weiss means repeated retching producing esophageal mucosal tears. Okay, that is Mallory-Weiss syndrome. Or is it gastric cancer? The confusion could be between varices and peptic ulcer. As per textbook reference, it is peptic ulcer. Peptic ulcer is more likely to produce upper GA bleed than an varus. Okay, only thing is, see, peptic ulcer bleeding patient presenting with vomiting would be much less common. Usually, peptic ulcer patients will present with bleeding and subsequent melena. Patient doesn't usually have vomiting, whereas variceal bleeding, because it occurs suddenly and large amounts, will stimulate vomiting also. So, patient usually presents with hematemesis. Okay, whereas the commonest cause of upper GA bleed per se is a peptic ulcer disease. Which of the following is the most common cause of large bowel obstruction? We discussed about bowel obstruction earlier. This is large bowel obstruction. Is it cancer, volvulus, diverticulitis, or adhesions? So, if the question includes large bowel, then the answer is malignancy. Okay. So, colonic cancers are more likely to produce a bowel obstruction than other pathologies in the large bowel. Okay, additions very rarely involve large bubble. Why? It is quite logical, right? You have the small bubble for which there are many, what a large length of the small bubble is mobile. It is suspended on a masonry. It can travel this way, that way, and get caught in the additions. Whereas colon, luckily or unluckily, you have got the cecum, then the ascending, which is retroperitoneal and fixed, then the hepatic flexure, transverse, which is mobile, but then again you have the descending, which is fixed behind the peritoneum, and the sigmoid, which is mobile. Rectum again fixed. So the colon is not as free to move as in the case of a large bowel. Okay, hence it doesn't get caught in additions as frequently as small bowel. Okay, yes. Which of the following is the most common cause of acute limb ischemia? That it is acute limb ischemia. Atherosclerosis, thromboembolism, trauma, or Raynaud's disease. Raynaud's disease, as you know, is an vasospastic condition. So atherosclerosis can cause limb ischemia, but it is chronic. Your classical final year exam case, peripheral occlusive vascular disease, most commonly caused by atherosclerosis. Whereas acute limb ischemia is most commonly caused by thromboembolism. That too, embolism is supposed to be much more common. From a cardiac source, you have cardiac, so infective endocarditis or a valvular heart disease producing a cardiac embolus, producing the acute limb ischemia. Which is the commonest cause for secondary hyperparathyroidism. Secondary hyperparathyroidism means the parathyroid was normal. Due to some metabolic cause, it has led to increased secretion of the parathyroid glands. So, among these, chronic kidney disease, vitamin D deficiency, adenoma, of course, will cause primary hyperparathyroidism. Men will also cause primary vitamin D deficiency, chronic kidney disease. It is usually chronic kidney disease because in patients who have chronic kidney disease, due to the impaired renal excretion, they have retention of phosphates as well as reduced production of vitamin D, calcitriol production. So this in turn will stimulate the parathormones to produce excess parathormones. You have hyperparathyroidism, which will later lead on to hypercalcemia. Okay. So, which among the following is the most common cause for acute mesenteric ischemia? Is it arterial embolism, thrombosis, venous thrombosis, or there is a condition called non-occlusive mesenteric ischemia or NOMI? Okay, among these, the answer is an embolism. Again, just like limb ischemia, bowel ischemia also is commonly caused by arterial embolism. Okay, a cardiac condition usually producing a shower of emboli which can get lodged into the mesenteric vessels. A young female presenting with severe headache, neck stiffness. What is the most likely diagnosis? Is it a migrainous headache, an SAH, subarachnoid hemorrhage, meningitis, or tension headache? So the catch here is neck stiffness. Severe headache can be caused by migraine, can be caused by meningitis, etc. So neck stiffness means there is a meningeal irritation. Sudden severe headache is a typical presentation of an subarachnoid hemorrhage, usually due to rupture of an intracranial berry aneurysm. It's also called as a thunderclap headache. So if you were listening to the sounds of the thunder, it is like a sudden and loud, just like you suddenly light a large cracker like that. Okay, like that. So this will be a severe onset sudden headache, because when the aneurysm ruptures, the blood suddenly fills the subarachnoid spaces. So patient gets severe headache, as well as this will irritate the meninges, producing neck stiffness also. Okay. Which is the most common reason for acute diverticulitis. So you have diverticula, means outpoachings from the bowel, commonly seen in the large bowel. There is a diverticulum, that's called diverticulosis. Now the diverticulum is getting inflamed, diverticulitis. What is the common cause? Is it due to infection, obstruction, ischemia, or trauma? In the case of diverticulitis, the most common is obstruction. Again, here, just like appendicitis, the culprit is a fecolith. You have fecal matter, it is getting inspissated and hard, so it is going to sit at, just you can imagine a cave. So a rock is blocking the entrance of the cave, like that. Okay, so the entrance to the diverticulum is blocked by the fecolith. So diverticulum becomes inflamed. The mucus will get inflamed. You get diverticulitis. The problem is this can even lead on to perforation also. Diverticular perforation also. So, which is the common cause for primary hyperparathyroidism? Earlier we discussed about secondary. Now this is primary. Is it adenoma, hyperplasia, carcinoma, or MEN? The cause for primary hyperparathyroidism most commonly is an adenoma. See, adenoma means it's usually solitary. It occurs in one of the parathyroids. Hyperplasia will usually involve all four parathyroids. Carcinoma also is only usually solitary, but carcinoma is not that common as compared to adenoma. Men also will produce diffuse hyperplasia. So solitary adenomas are the usual cause for hyperparathyroidism in the primary. So what's the difference in the treatment? If it's an adenoma, you just need to localize the adenoma and remove that parathyroid alone. You do not need to remove all four parathyroids. കാർഡ് അടച്ച് പിടിപ്പിക്കേണ്ട കാര്യമില്ല. You can just remove the culprit parathyroid and then retain the other three. Whereas if it's a parathyroid hyperplasia, which means all four parathyroids are secreting abnormally, you need to remove three. There's a concept of removing three parathyroids or three and a half parathyroids. Means you remove three, take the fourth, and remove it in half, and keep the half either in the neck itself or you implant it into the forearm. That's a different discussion altogether. But understand that for adenoma, you just need to do a parathyroidectomy of the involved parathyroid alone. Whereas hyperplasia, you will need to usually remove all the culprit parathyroids. Yes. Which is the common cause of acute appendicitis in children? So the commonest cause of acute appendicitis was obstruction caused by fecolith, whereas in children it is not fecolith. Children don't usually develop fecolith. Okay, they have not yet developed all the adult lifestyle habits leading on to constipation, insipid fecal matter, etc. Okay, so in case of children, usually it is lymphoid hyperplasia. Okay, so it is usually caused by viral infections. So children, because they are not yet developed immunity to most of the infections, if there is a viral infection, even sometimes a common cold or a rotavirus, anything can produce lymphoid hyperplasia. So this can produce obstruction of the appendicular lumen, producing acute appendicitis. And parasites like roundworms can rarely cause, foreign bodies are not very common. Okay, so in children it is lymphoid hyperplasia, which is the most common cause of chronic pancreatitis. Earlier we discussed about acute pancreatitis and there the answer was gallstones. Here it is just the opposite, that is alcohol. So if you look at the textbook, alcohol causes more of chronic pancreatitis, gallstone causes more of acute pancreatitis. Okay, so keep that always in mind. Yes, so alcohol, chronic, gallstones, acute. So alcohol is the most common cause of chronic pancreatitis. Yes, so you have epididymoorchitis. So which is the pathogen organ in young men? Young means usually under 35 years of age, or in other words, sexually active men, which is the culprit organism. Among these, it is Chlamydia trachomatis. Okay, that is why when you have epididymoorchitis in young men, we treat with doxycycline usually, which can be effective against Chlamydia trachomatis. So in young men, it is usually caused by Chlamydia trachomatis. In older men, it is usually E. coli. It is due to urinary infection, which is again commonly caused by E. coli. A young male presenting with a painless transilluminant swelling in the scrotum. What is the most likely diagnosis? So, transilluminant swellings in the scrotum, there are two types. One is hydrocele, the other is epididymal cyst. Both of these are transilluminant. Among these two, epididymal cyst is more transilluminant, also called as the brilliantly transilluminant, but that is not so common. So if you are given both options, there can be a confusion. But since we have only hydrocele here, the answer here is hydrocele. Varicocele usually presents as a swelling not in the scrotum but in the spermatocord. Testicular tumors are characteristically solid swellings. You won't get any transillumination. Spermatocele also has got whitish liquid. It is not transilluminate. So vaginal hydrocele, that is the called vaginal hydrocele is the other name for the adult hydrocele. So that will have the typical trans illumination, which is the most sensitive modality for detecting CBD stones or choledocholithiasis. Okay, most sensitive. Is it X-ray? See, for renal stones, X-ray is useful because the renal stones are mostly radio opaque. Okay, whereas gallbladder stones, CBD stones are not that commonly opaque as compared to renal stones. Ultrasound is good. CT is not that good as compared to other ultrasound or MRI. MRCP, magnetic resonance cholangiopancreatography, is the investigation which has got maximum sensitivity. Okay, so the best investigation or most sensitive investigation is an MRCP. We can visualize the entire biliary tract and all the gall stones also, CBD stones, etc. etc. Ultrasound is good but not that sensitive compared to an MRCP. Which is the most common cause of postoperative fever on the second day after surgery? See, if you look at the causes for postoperative fever, there are these various wind, W, that is wind, wound, walking, etc., etc. That is, it can be due to deep venous thrombosis. It can be caused by lung complications. Then it can be caused by surgical site infection. It can be caused by urinary infection, etc. But the most common cause for fever on the second day after surgery is atelectasis, that is lung complications. Surgical site infections will usually set in on the from the third day onwards only, not from the second day. Urinary infection can occur supposing the patient is catheterized. DVT can also produce secondarily lung complications and fever also. So atelectasis, because why? Because patient has remained in the recumbent state for a prolonged time during the surgery as well as on the postoperative period also. The patient will be more comfortable lying down than walking around. Okay, hence it causes atelectasis. The basal segments of the lung will not move. There will be hypostatic conditions there producing infection. Which is the most common cause for secondary peritonitis? See, primary peritonitis means there is no inciting factor. The patient gets peritonitis by without any specific cause. It is usually called as a spontaneous peritonitis also. Patients who have ascites, they can develop SBP, okay, or in patients with other conditions also. So, which is the cause for secondary peritonitis? Among these four, that is appendicitis, diverticulitis, pancreatitis, or perforation, the commonest cause is perforation. So what happens is you have an ulcer, it perforates, the stomach contents goes into the peritoneal cavity, which will irritate the peritoneum, producing a peritonitis, secondary peritonitis, which is the most common cause of acute limb ischemia in patients with atrial fibrillation. See, earlier also we told the most common cause of acute limb ischemia is embolism. Same thing. It is all the more confirmed because here the question is more specific. Atrial fibrillation. So patients with atrial fibrillation, it is told that the atrium will become a fibrillating bag of worms. It contracts. It doesn't contract properly. It is just not twitching. So there will be no complete evacuation of the atrium, the blood. So it can lead to formation of embolus, thrombus in the atrium. This can dislodge and produce limb ischemia. Okay, so hence what you do in patients with chronic AF, usually you put them on oral anticoagulants. A young female 30 years old presenting with a thyroid nodule and elevated calcitonin. So which of the cancers is more likely here? Here the catch is the calcitonin. The patient has an elevated tumor marker. Calcitonin is the tumor marker for medullary thyroid carcinoma. For papillary, you have thyroglobulin. Follicular, not specific, but if at all you look for, you can look for thyroglobulin. Anaplastic, there is no tumor marker. Medullary, you have calcitonin and CEA, that is carcinoembryonic antigen also as the tumor marker for medullary carcinoma of the thyroid. Medullary also is the one which is seen usually in association with MEN syndrome. Which is the commonest cause for primary spontaneous pneumothorax? It is primary. There is no underlying any major lung pathology. It is spontaneous, not following any condition. Is it trauma? No, trauma obviously can't be primary, right? So COPD, or whether it is a tuberculosis or subpleural bleb, the common cause is subpleural bleb. Especially thin, tall, young males, they can have subpleural blebs. So due to some cause, without any specific reason, this bleb will rupture, which will cause leakage of air into the pleural cavity. Which of the following is the most common cause for acute mesenteric vein thrombosis? Is it a hypercoagulemia, or is it trauma, portal hypertension, or infection? See, among these, the commonest cause is hypercoagulable states. For acute mesenteric venous thrombosis, the cause is hypercoagulable state like either an APLA syndrome. Can have various causes for hypercoagulability, including protein C deficiency, protein S deficiency, then APLA syndrome, vasculitis, etc. Okay, here it is usually caused by hypercoagulability. Which is the commonest cause for acute appendicitis in elderly patients? See, among all patients, it is fecalith. In children, it is lymphoid hyperplasia. What about adults? We have the other extreme. Okay, though fecalith is there, the commonest cause usually is colorectal cancer. See, you have a colorectal cancer which is obstructing the lumen. There is back pressure. This back pressure will cause the appendix to become distended and inflamed. Okay. So, which is the common cause for acute epididymitis in men over 35? You already discussed this answer, that is E. coli. Here, the cause is usually urinary infection. One of the common organisms which can cause urinary infection in men or beyond 35 years of age is E. coli, sometimes Klebsiella, etc. Okay. So, the previously gonococci, that is Neisseria, was very common, but nowadays we very rarely see gonococci because penicillins are being used commonly for skin infections. That is killing the gonococci also. So you are not getting gonococcal infections nowadays. Whereas other urinary pathogens, including E. coli, Klebsiella, etc., can be seen. And among them, the commonest culprit in men over 35 is E. coli. which is the commonest reason for acute compartment syndrome. So, compartment syndrome, I told you, where there is increased intracompartmental pressure. The commonest reason is fracture, especially in the leg, usually which is seen in the lower leg, that is at the site of the tibial fractures. Due to the fracture, there can be fracture hematoma. So, if the compartment is not disrupted, if the facial compartment is intact, this hematoma will increase the intracompartmental pressure. So, you get all that peace, pain on passive movement, pulselessness, paresthesia, paralysis, etc. etc. Okay, all the other is burns also can compartment syndrome can cause, especially in the limbs. Crush injury can cause, vascular injury can cause, but the commonest reason is fracture. So among you have a different set of patients. Immunocompromised patients, which is the most common cause for acute appendicitis. So, among these, one of the most common opportunistic infections in HIV patients usually is cytomegalovirus. So, this cytomegalovirus you don't see in immunocompetent patients. It is seen commonly in immunocompromised patients. It can produce appendicitis by various mechanisms. You can get inflammation, also lymphoid hyperplasia. So, due to this multitude of factors, you have appendicitis. Okay, which is the common cause of acute pancreatitis in patients with HIV? So this is common cause for acute pancreatitis, not appendicitis, in patients who have HIV infections. It is the options being given: gallstones, ART, trauma, alcohol. It is ART, especially didenosine. Okay, DDH or didenosine is a specific etiologic agent for acute pancreatitis in patients who are having HIV. Which is the most common cause of appendicitis in patients with cystic fibrosis? Okay, so in patients with cystic fibrosis, the most common cause of appendicitis is mucus plug. See, cystic fibrosis patients have impaired mucus clearance. The secretions are thick. They have respiratory complications, GIT complications, sinusitis, etc. So one another complication is mucus plug formation producing acute appendicitis. Okay, so I have been discussing for 1 year, just 1 minute break, okay, for you also, because you all have been listening for this. Not too much, just 1 minute break. I'm just taking 1 minute break. I'll be back in a minute, okay? Yes, hope you all also had a small break. Okay, yes. So, which is the commonest cause of acute appendicitis in patients with IBD, inflammatory bowel disease? Okay, among the inflammatory bowel disease, you have mostly ulcerative colitis and Crohn's. These are the two common causes for inflammatory bowel disease. Of this, Crohn's is a very common cause for acute appendicitis. So the Crohn's will produce transmural inflammation. That means inflammation of the bowel wall. That can lead to increased incidence of appendicitis. Okay. So again, another question on Crohn's. Which of the following is a characteristic feature of Crohn's? Is it continuous involvement of the colon or skip lesions where you get one lesion with a gap in the mucosa, or is it involvement of rectum or occurrence of toxic megacolon? The answer is skip lesion, because Crohn's usually does not produce continuous colonic involvement. It usually spares the rectum, and toxic megacolon is not seen in Crohn's. It is characterized by skip lesion. Okay, that means you have pathologic tissue in between with healthy tissues. So this is just a table which gives the main features, differences between ulcerative colitis and Crohn's, because this also I have seen in some of the question papers. They will give some of the features. So maybe three features from ulcerative colitis and one from Crohn's, and ask you what is the probable condition, like that. Okay. So ulcerative colitis usually involves the colon, mainly the rectum, and it usually involves an abnormality in the T helper cells 2 type 2, that is a Th2 cells. There is an involvement of the mucosa and submucosa only. The lesions are continuous, and microscopically usually you can see crypt abscesses. Complications include ulceration, bleeding, fulminant colitis, toxic megacolon, sometimes perforation, and also a very high chance for developing colorectal cancer. Treatment wise, you have various options, basically immunosuppressants. Whereas surgery, if you do in ulcerative colitis, usually you go for a total colectomy. Okay, total proctocolectomy, it is curative. The surgery is curative. Whereas in Crohn's can involve almost all of the GAT, small bowel, large bowel, sometimes even stomach, very rarely, etc. But rectum is spared. For some reason, rectum is spared. And here the pathognomonic, the culprits are usually the helper cells type 1. There is a transmural involvement. That is, the entire thickness of the bowel is involved, and you don't have continuous lesions, you have skip lesions. And one characteristic finding is granuloma formation. In tuberculosis, you get caseating granuloma. In Crohn's, you get non-caseating granuloma. And as opposed to ulcers in ulcerative colitis, you get strictures and obstruction and fistulas, occurrence of fistula in whereas the risk for colorectal cancer is low in Crohn's. Treatment also is with immunosuppressants. Only thing is, surgery in Crohn's is not for cure, but for treating the complications alone. If you have a stricture, you can go for surgery. If you have an obstruction, go for surgery. But that doesn't cure the disease. What is the first line treatment for a patient with a tension pneumothorax? A patient presents with tension pneumothorax means patient has absolute what lack of movement of one side of the chest wall, that is completely filled with air. There is hypertension. The neck veins are distended. How do you treat this? The ideal treatment is a chest tube insertion, but here the question is first line treatment, because it's a surgical emergency, and if you wait, sometimes you might end up losing the patient. You cannot intubate unless you put the tube, because if you intubate and give positive pressure ventilation, it might even make the pneumothorax worse. Okay, so here the emergency management is a needle thoracostomy. Okay, needle thoracocentesis, where you put the needle. The textbook still says second intercostal space along the midclavicular line, whereas if you look at the ATLS guidelines, the current ATLS guidelines would quote this as fifth intercostal space along the anterior axillary line. But because you are supposed to follow textbooks more, you can still say, for the exam, you can still quote it as second intercostal space along the mid clavicular line. Okay, needle thoracocentesis. What is the most common site for adult volvulus? Is it the sigmoid, cecum, transverse rectum? You might even get stomach. Stomach also is a site. But among all these, the commonest site is sigmoid. Okay, sigmoid volvulus is the commonest site. It is told that because the sigmoid has got a redundant mesentery, and sigmoid will usually become distended with fecal matter. These are the reasons for the occurrence of sigmoid volvulus. Okay, and it usually might is a surgical emergency, and X-ray wise you can get, sometimes you might get an X-ray showing the omega sign or the bend intertube sign with the history depicting intestinal obstruction. What is the likely diagnosis? With a sigmoid colon, so sigmoid volvulus. What is the most common benign tumor of liver? Is it adenoma, angioma, hepatocellular carcinoma? Obviously, no. You know it is not benign, or FNH, focal nodular hyperplasia. The commonest benign tumor is hemangioma. See, if you have, supposing your batch, MBBS batch, 100 students are there. If you randomly do an ultrasound of these 100 students, you might pick up asymptomatic hemangiomas in at least 10 of these. Okay, so hemangiomas are very common, but they are mostly asymptomatic. When you do an imaging for some other pathology, supposing the patient has abdomen pain, you take an ultrasound, you may detect hemangioma as an incidental finding. It usually does not produce any symptoms. A 64 years old patient, woman, presenting with upper abdomen pain, generalized itching and jaundice. What is the most likely diagnosis? So upper abdomen pain can be pancreatitis, but there is itching and jaundice. So itching and jaundice means it is obstructive jaundice. So when you get the word itching along with jaundice, keep in mind it is obstructive jaundice. So among these conditions which can produce obstructive jaundice, pancreatitis, of course, acute cannot produce obstructive jaundice. Cholecystitis cannot produce obstructive jaundice. It can produce hepatic jaundice in its late stages, okay, or medical jaundice. Whereas hepatitis also can very, very rarely produce obstructive jaundice. But obviously, choledocholithiasis, that is CBD stones. What is the problem here? CBD stones obstructing the CBD. So the bile cannot freely flow into the bowel. It produces jaundice. Obstructive jaundice means patient will have uh, itching, clay colored stools, etc. Okay. Yes. A patient, a 45 years old male, has got sudden onset severe epigastric pain radiating to back. History of alcohol abuse. There should be no confusion. This should be diagnosed as acute pancreatitis. This radiation to back and alcohol abuse. There is no confusion. This is acute pancreatitis. Okay. Alcohol can cause gastritis, but then you won't get that radiation to the back. Okay, peptic ulcer also, posterior ulcers can produce radiation of pain to the back, but usually you won't have this history of alcohol abuse. Okay, so typical this combination occurs. Always think about pancreatitis. Okay, okay, a 30 years old female with a palpable thyroid nodule of size 3 by 4 centimeter, a comparatively large nodule. FNAC reveals papillary carcinoma. What is the management? So will you go for thyroidectomy? That is total. Will you go for lobectomy? Will you observe, or will you go for a radioactive iodine ablation? See, thyroid cancers, if you are asked in one word what is the treatment, it is thyroidectomy. Okay, there is no medical management for thyroid cancers. Again, thyroid cancers, what is the management? What is the surgery? That's what type of surgery means you can safely say it is total thyroidectomy. Okay, only thing is in very, very limited conditions, in exceptional cases, you can stop with a lobectomy. Okay, lobectomy means it is something, it's lobectomy is also called as hemithyroidectomy. The words are used interchangeably in Bayesian law. Hemithyroidectomy or lobectomy means removal of the lobe along with the isthmus. Okay, so if it is a very small nodule, like less than 2 centimeter size, and if the patient has no adverse features, that is, the patient is of the optimal age, patient does not have any extra thyroidal extension, the patient doesn't have any lymph nodes. If all these conditions are satisfied, okay, the patient is optimal, then you might stop with a lobectomy. In all other conditions, you have to go for a total thyroidectomy. Okay, that is any nodule more than 2 centimeter, obviously. Then, if there are features of extra thyroid extension, or if there are lymph nodes, all these you have to go for a total thyroidectomy. And also, this lobectomy is done only in papillary carcinoma. In follicular, it is total, medullary, it is total, anaplastic, it is total. But anaplastic, sometimes surgery might not be feasible because it is a locally invasive cancer. By the time you make a diagnosis, the patient might have had an inoperable cancer. That's a different scenario. But except in some cases of papillary carcinoma, all other thyroid cancers, the treatment is total thyroidectomy. So here, because the size is large, you have to go for a total thyroidectomy. If there are lymph nodes, you have to go for a lymph node dissection also. Okay. Yes. A 70-year-old man presenting with hematuria. What's the most likely diagnosis? See, smoking is a definite risk factor for bladder cancer. So, hematuria, smoking, you should suspect a bladder cancer. Okay. Otherwise, if it was simply hematuria, you can of course think about stones, renal cancer, etc. Urinary infection, even BPH also is possible. But smoking, hematuria, bladder cancer. So the investigation, yes, I think there's a question on that. We'll see that. Okay, a 55 years old female presenting with breast lump, and the mammography shows a spiculated mass. Spiculated means Spiculation means spines. No, just like you have spines, just like you have the മുള്ളമ്പന്നിയുടെ പുറത്തുള്ള മുള്ളു പോലെ. It's a spiculated mass. What is the most likely diagnosis? Spiculated mass is a typical feature of breast carcinoma. Okay. So fibroadenoma, you won't have spiculated mass. Fat necrosis can sometimes mimic, but again not too typical. A spiculated mass mammography. See, mammography wise, what are the features of malignancy? If it has got irregular shape, if it's a very high dense mass, or if it has got microcalcifications, that is clustered microcalcifications, if there is architectural distortion or any asymmetry which has occurred newly, or there is any skin changes including retraction, ulceration, or enlarged lymph nodes. Any features in the mammography is suggestive of a malignancy. Mammography, if you remember, is reported with the BIRATS, breast imaging reporting and data system, grades from 0 to 6, 0 being negative, 6 being malignant, and anything else comes in between. A 60 years old male presenting with progressive dysphagia to both solids and liquids. Barium solo shows bird beak appearance. What is the most likely diagnosis? So this bird beak appearance means it is typically seen in achalasia cardia. Okay. So there is a classical teaching that in achalasia you will have dysphagia more to liquids than solids, but it is not that conclusive. Okay, so it is, though it is commonly clinically quoted, practically we don't see that. Practically the patient will have dysphagia both to solids as well as to liquids. Okay, so it occurs usually in achalasia cardia with the barium solo showing the typical bird beak appearance. Okay, whereas if it is a malignancy, esophageal cancer, you will have irregular appearance, not the typical bird beak appearance. A patient with a history of gallstones, okay, a middle-aged female, now having fever, jaundice, right upper quadrant pain. What is the diagnosis? So the patient has got a history of gallstones. Now fever, jaundice, and upper quadrant pain. Here the confusion might be between cholangitis and cholecystitis. The catch here is the jaundice. Jaundice is usually not seen in acute cholecystitis. Okay, cholecystitis, you might have fever, you might have upper quadrant pain, you might have vomiting, etc. But jaundice is very, very unlikely. Whereas cholangitis is seen in patients who have jaundice. Hepatitis, there is no relation with the gallstones. Pancreatitis also has got no relation with the gallstones. Okay. Yes. So, if the patient has a combination of fever, jaundice, and right upper quadrant pain, it's also known as the Charcot's triad. It indicates cholangitis. When you add two more features, that is hypertension and mental obtundation to this, you call that as Raynaud's pendant. Okay, that's also a feature seen in cholangitis. So, cholangitis, you get the Charcot's triad, or sometimes the very rarely Raynaud's pendant also. It is 5 of them. Okay, a 40 years old male presenting with painless solid testicular mass. What is the most likely diagnosis? So it is painless. So it is unlikely to be torsion or epididymitis, both of which are characterized by pain. It is solid. So it is unlikely to be hydrocele. So the most likely diagnosis is a testicular cancer. Okay. So painless testicular cancer mass means we should suspect a cancer. So these are the most common testicular tumors: seminoma, non-seminomatous germ cell tumors, embryonal carcinoma, yolk cell tumor, choriocarcinoma. Then also you have Sertoli and light cell tumor also. These are the typical features. I'm not going to describe. I will share the slides with you. You can probably read from that. Okay, otherwise we'll be very late. Okay. Now, a 35 years old female is presenting with a history of recurrent peptic ulcers and diarrhea. What is the most likely diagnosis? So recurrent peptic ulcer diagnosis, there is the typical diagnosis is what is called as Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is usually caused by a gastrinoma, that is gastrin secreting tumor. You have the triad, that is a tumor in the pancreas or duodenum, which secretes gastrin. So there is a stimulatory effect on the gastric cells, which will secrete too much of hydrochloric acid, which will lead to peptic ulcer. So usually the patient will present with recurrent ulcers, which recur in spite of proton pump inhibitor treatment. Patient will also have diarrhea because of the secretion of the other stimulatory chemicals also. Okay, a patient who is having acute abdomen pain, the CT shows what is called as a target sign. What is the most likely diagnosis? Target sign means if you remember our archery shooting, you see those various colors of the target, a circle, right, with multiple rings. That is what is called as a target. So it is a typical finding seen in intussusception. Okay, so intussusception, if you take the CT, you get something called as a target sign. Ultrasound, it is also called as a donut sign or pseudo kidney sign. It is in various views. Because of the bubble within bubble appearance, we have this finding. That is the intussusception. Okay, these are the findings. Okay, that is a on. Yeah. So a 60 years old male presenting with, I told you the similar history earlier, 60 years old male smoking presenting with painless hematuria. What is the next best step? So we are suspecting what? Bladder cancer. You suspect bladder cancer, what is the investigation of choice? Is it a culture? No, because culture is good for UTI. Plain CT? No. You want a contrast CT to identify a cancer. Plain CT is good for usually stones, cystoscopy or renal biopsy. Because you are suspecting bladder cancer, a renal biopsy cannot be helpful. So here it is cystoscopy. Okay. Sometimes the question can be given as cystouretroscopy also. Okay. Both are the same. Cystoscopy means you are visualizing the bladder to see the growth and take a biopsy. Okay, so which of the following drugs is contraindicated in acute pancreatitis? Metrogyl, mostly you might get sometimes all the choices would be with M, methotrexate, metronidazole, the morphine, mefendramine, etc., etc. Because obviously the answer is starts with an M, that is morphine. Okay, so what occurs is that morphine has got an effect of increasing the contracting the sphincter of OD pressure. Okay, so that means the intrapancreatic pressure will increase. The pancreatic enzymes cannot freely flow into the bowel. Hence, morphine is not given as an analgesic in patients with acute pancreatitis. Tramadol might be given, but not morphine. Which artery is most commonly involved in mesenteric ischemia? Okay. Is it the SMA, IMA, celiac artery, or the renal artery? Mesenteric ischemia, obviously, you know, it cannot be caused by renal. It is one of the three major vessels, that is celiac, so SMA, or the IMA. It is SMA. Okay. Most commonly in mesenteric ischemia, the SMA is the involved vessel. Okay, so yes. SMA supplies the areas which have derived from the foregut, whereas the IMA supplies, sorry, the celiac artery supplies the parts of the bowel which have developed from the foregut. SMA parts which are developed from the midgut, and the inferior mesenteric artery supplies those parts which are developed from the hindgut. Okay, yes. Which scoring system is used to assess the severity of acute pancreatitis? You have various scoring systems, but the most classical one in acute pancreatitis is Ranson's criteria. Okay, Glasgow Coma scale obviously is for head injury. Child-Pugh and MELD are for liver disease, whereas Ranson is used for acute pancreatitis. Very rarely I have seen questions about which of the following is an ingredient of Ranson criteria or which of the following is not. Sometimes you might. So it might be better to have some mnemonic. See, when I was I used to remember this with a mnemonic of my own. So you can form your own mnemonic. Okay, memory aid to keep this in mind. So at age, it is the age, then the WBC count, blood glucose, AST, LDH. After 48 hours, the calcium values, PCV, oxygen, the PaO2, then increase in blood urea, nitrogen, base deficit, or fluid sequestration. These are the classical ones which is used in Ranson criteria. And nowadays you have other criteria also, including the Apache, the possum, etc., etc. Okay, but Ranson is usually specific for pancreatitis. And this is regarding the child pew and the MELD. Child pew and MELD are both used for chronic liver disease. MELD stands for model in end stage liver disease. Thing is, child pew is usually used for clinical classification. So based on whether the patient is child A, B, or C, you can categorize the severity of the disease. Whereas MELD is usually for prioritizing for liver transplant. A patient with a MELD 30 will be given a priority over a patient with a MELD 20, like that. Okay, so that is the difference. Okay, which of these suture materials is absorbable? Silk, nylon, vicryl, or proline? And the vicryl is otherwise polyglactin. Okay, you might be tempted to say it is silk, but the answer here is vicryl. So polyglactin is an example of a synthetic absorbable material. You have polyglactin, polyglycolic acid, polyglycapron. All these are examples of synthetic absorbable materials. Whereas naturally absorbing, you have the catgut. Okay, silk is an example of a naturally occurring non-absorbable material, whereas nylon and polypropylene are synthetic non-absorbable. Yes. So, okay, there is a study. Somebody has done a study, and the p value has come as less than 0.05. What does that mean? Does that mean that the result is statistically significant, or it is clinically significant, or that the null hypothesis is true, or that the study is biased? So you do get questions from research because it has been given importance nowadays. So when you do studies, you have a null hypothesis. See, for example, you are saying that a drug, say you want to discuss and say that a new drug B, is superior to losartan in treating hypertension. So your hypothesis, that is the alternate hypothesis, is that drug B is better. The null hypothesis states that no, there is no difference. Losartan and drug B are equally good, or like that. Okay. So when you have a p-value which is less than 0.05, what it means is that the result is statistically significant. So what that means is that your null hypothesis is wrong. That is, there is strong evidence against the null hypothesis. So you reject the null hypothesis. That means your alternative hypothesis is accepted. Or you will find, if your value is less than 0.05, you can say that there is a higher chance that the drug B is better than losartan in treating hypertension. Okay, so this is the inference. Yes. So a 50 years old male with cirrhosis presents with hematemesis. We told this, we discussed this earlier. The likely cause is obviously esophageal varices. Okay. Cirrhosis presenting with hematemesis because of the portal hypertension and the subsequent formation of the varices in the esophagus. A 35 years old male presenting with severe abdomen pain and vomiting. Imaging reveals perforated ulcer. What is the definitive management? So, in other words, what this question is asking is, how do you definitively manage a perforated ulcer, a perforation peritonitis? You can't obviously go for conservative management. You can't do any endoscopic clipping, or a nasogastric suction is good in the casualty setup. That doesn't treat the ulcer per se. So the definitive treatment is with an immediate surgical intervention. That means you do a laparotomy or a laparoscopy, whatever, depending on your expertise. Visualize the ulcer, you close the ulcer, because otherwise this will go on oozing the contents into the peritoneal cavity. Okay, so immediate surgical intervention. Yes. A male patient presenting with painful scrotal swelling, Doppler shows testicular torsion. What is the management? So in torsion, there is no conservative management. There is a saying that is time is testis. That is, if you lose time, you are going to lose the testis also. So the moment you diagnose a torsion, you have to prepare the patient immediately for surgery and do it at the earliest. Because it is told that if the testis is completely twisted and if it remains like that for more than 6 hours, the testis will go into gangrene. So what is the problem? You are going to lose the testis. That is, you will have to remove the gangrenous testis. And there is a much more complicated problem. Testicular gangrene might produce what is called a sympathetic orchitis. That is, the body itself develops auto antibodies to this testicular cells, and this is going to damage the opposite normal testis also. So the patient might end up having loss of both testes. It is complete sterility or infertility, whatever. Okay. So the treatment of acute torsion is to go for immediate surgical exploration. If the testis is viable, save it. If it is not viable, remove it so that the body doesn't get time to form antibodies and subsequently destroy the opposite testis also. Okay. Yes, a patient with a history of breast cancer undergoes mastectomy, and as a late complication, the patient develops a seroma. How do you manage? So, what is the management of a seroma? That is the gist of this question. So, seroma is usually, unless it is infected, you need not do any surgical exploration. You can just aspirate the seroma and then give an elastic compression bandage. Okay. The problem with seroma is if you leave it, it can remain there and produce infection secondarily. Okay, other problems. So you can aspirate the seroma. Sometimes the patient might need repeated aspiration also. But the best option is aspiration and then apply compression bandage and send the patient. Okay. Yes. A patient presents with a painful swollen leg. Doppler reveals deep vein thrombosis. What is the management? So sometimes you might get a swelling like this. A patient presents and with a painful swollen leg, and Doppler shows a filling defect in the deep veins, or it might say that the Homan sign is positive. Okay, some other clue might be given. So you will have to diagnose it as deep vein thrombosis, and you also have to mention the management. The definitive management for deep vein thrombosis is anticoagulation therapy. You don't go for thrombectomies. See, thrombectomies are done for arterial thrombosis. If you have a carotid thrombus, okay, you might go for a thrombectomy or atherectomy. Whereas with deep veins, you don't go for thrombectomies because you have the superficial veins. So even if the deep veins are obstructed, the patient's blood will be taken through the superficial veins. Okay, so you need not go for a thrombectomy. Compression stockings are not useful in established deep vein thrombosis. They can prevent maybe deep vein thrombosis but not treat. Bed rest also might be given in the earlier stages, but that is not the definitive treatment. Definitive treatment is you give anticoagulation therapy with the heparin or low molecular weight heparin, unfractionated heparin, and then once you achieve the desired levels of the APTT, you start the patient on oral anticoagulant, that is warfarin or decumarin, and then you achieve the required prothrombin time INR. Usually it is between 2 and 3, and you have to continue this. Okay. Usually the first episode you give for 6 months, and if it's a recurrent, you might have to continue for longer periods. Okay. A patient presenting with jaundice and abdomen pain, imaging shows choledocholithiasis. What is the best management approach? So, what is the ideal management for a stone in the common bile duct? That is the question. Is it open cholecystectomy, laparoscopic cholecystectomy, conservative management, or endoscopic retrograde cholangiopancreatography, ERCP? See, for diagnosis, you might use MRCP, but ERCP is more beneficial because it is diagnostic as well as therapeutic. You are putting an endoscope, you are visualizing the common bile duct, you can see the stone, and then you can put a Fogarty's catheter or maybe a Dornia basket and then retrieve the stone also. And you can do a sphincterotomy, means You dilate the sphincter of OD to allow the further stones to come out. You might even add a stent to keep the bile duct open. Okay, so definitive management of common bile duct stone is ERCP with or without sphincterotomy, with or without stenting. Okay, and do you need a cholecystectomy? Yes, of course, but usually it is done later. The usual practice is to do an ERCP and then after some weeks you go for a cholecystectomy because majority of the CBD stones have their origin in the gallbladder. They originate in the gallbladder and migrate to the CBD. So if you keep the gallbladder, the patient has got a recurrent chance of developing CBD stones. So then you have to remove the gallbladder. And nowadays the gold standard treatment for gallbladder removal is laparoscopy. Okay. So if you are asked in a single, like a one word answer, a one sentence answer, what is the optimal treatment, then you can say ERCP plus laparoscopy cholecystectomy. Okay, because this is a single best option, you have to go for ERCP. Or you might get an option of ERCP followed by laparoscopy chole, then means you have to choose that. Okay, have to remove the stone, you have to dilate the stone, then you have to remove the gallbladder also in all cases. Okay, a 50-year-old patient presenting with progressive jaundice. Okay, progressive jaundice, weight loss, clay colored stools. The gallbladder is palpable and the USG shows features of obstructive jaundice in the form of dilated intrahepatic bile duct. What is the most likely diagnosis? Hepatitis will not produce such a picture. What about gallstones or pancreatic cancer? So there is a law. If you remember, there is a law which states that in a jaundiced patient, if the gallbladder is palpable, it is very or seldom due to gallstones. That's called as the Courvoisier's law. So as per this law, if the GB is palpable, your diagnosis should be towards malignancy. Patient has also got other features of malignancy. See, progressive jaundice, weight loss. Okay, yes. So jaundice, weight loss, dilated IHBRD, especially in the head of pancreas. A 35 years old patient presenting with a palpable breast lump. On examination, lump is mobile, firm, non-tender. So mobile, firm, non-tender, otherwise called as a breast mouse. There is only one possibility, that is fibroadenoma. Okay, so breast cancer will not be that mobile, will be hard. Okay, breast non-tender, hence it is not an abscess. Fibrocystic disease, you will not get a definite lump. It will be a lumpiness. It will not be mobile also. Can have a varying consistency. So it's a fibroadenoma. How do you treat fibroadenoma? Fibroadenomas do not need surgery mandatorily if it is relatively large or producing symptoms to cosmetic or producing pain. Then you can excise. Otherwise, it can even be left and observed. A 70 years old male presenting with difficulty in swallowing, weight loss, and regurgitation of undigested food. So that means there is a proximal esophageal, or there's a proximal GA obstruction is in the esophagus. There is weight loss. That means it's probably a malignancy. So such a patient has got most probably an esophageal cancer. Okay, so dysphagia, weight loss, and regurgitation of undigested food are examples of esophageal cancer. Especially if they supposing they say this patient is a past smoker or alcoholic, this is all the more conclusive. A 55 years old female presenting with recurrent episodes of right upper quadrant pain after fatty meals lasting for an hour. Ultrasound shows gallstones with no pericholecystic fluid collection. What is the most likely diagnosis? See, the one confusion is, see, very often when we get gallstones, we tend to call that as cholecystitis. No, cholecystitis is not equivalent to gallstones. That is gallbladder stones. You call gallbladder stones as cholelithiasis. Cholelithiasis is not the same as cholecystitis. For cholecystitis to occur, the patient should have fever and the pain will be prolonged. If the patient has typically recurrent episodes of RUQ pain, which is triggered by fatty meal, it lasts for around an hour only, and the ultrasound will show gallstones, but there will be no thickening of the pericholecystic spaces. The GB wall will be normal. That is what is typically called as the biliary colic. Okay, that is what is called as a biliary colic. That is, a patient has got a gallstone due to the contraction of the gallbladder after eating the food. The patient is having pain, but once the gallbladder slowly relaxes, the pain disappears. Acute cholecystitis, the patient will have fever, Murphy's sign. Okay, the USG will show thickened gallbladder, pericholecystic collection, etc. A 50 years old patient, again, just like your earlier case, painless jaundice and palpable gallbladder. So here there should be no confusion. Do not go for gallstones. This has to be pancreatic cancer. Okay. So painless jaundice, palpable GB, first diagnosis is a malignant jaundice according to Courvoisier's law. Okay, I think yes, we'll have some scenarios. Yeah, we will have some more questions and then probably stop. Okay. At 58 years old, the female is diagnosed with high-grade retroperitoneal liposarcoma. After treatment, if you are monitoring for metastasis, what is the most common site? Is it the lungs, the liver, the bone, or the brain? See, sarcomas, always keep in mind, sarcomas have got blood spread. Okay, blood spread means it spreads through the systemic circulation. So if something is spreading through the systemic circulation, that is spreading through the veins. That means it is going through the systemic veins, through the inferior vena cava. It is going into the lungs first. So all the intra-abdominal malignancies, they are likely to they get deposit on the liver if they are drained by portal circulation. See, colon, our stomach, pancreas, all these are draining through the portal venous circulation. Hence, their most common site for dropping metastasis is the liver. Whereas the retroperitoneum or the limbs, you have a sarcoma in the leg, sarcoma in the arm. All this is going to drain through the systemic veins. That means they are going to drop into the lungs first before going into other organs. Okay, so lungs. Okay, so retroperitoneal sarcomas are rare, but they are aggressive. Also, you have the types which can be liposarcoma, leiomyosarcoma, or malignant fibrous histiocytoma. Treatment is surgery. You have to debulk the tumor followed by chemoradiation, and the recurrence is relatively high. It is the nature of the disease itself. Sorry, how to do it? Yes. Yes, the a 67 years old male has got a gradually increasing bulge in the right groin. It becomes more prominent when standing and straining, can be reduced when lying down. The bulge is medial to inferior epigastric vessels. What is the correct statement? Is it a direct hernia? Is it an indirect hernia? If it is a direct hernia, is it passing through a defect in the abdomen wall or through the deep inguinal ring? If it is an indirect hernia, is it passing through a defect in the abdomen wall or the deep inguinal ring? See, obviously, you know that direct inguinal hernias come out through the Hesselbach's triangle. So, it is a weakness at the medial aspect of the abdomen wall, just medial to the inferior epigastric vessels and lateral to the rectus muscle. So direct inguinal hernias will enter the inguinal canal through the Hasselbalch's triangle and then enter the superficial ring, and then it will stay there. It will very seldom only enter the scrotum. Whereas indirect inguinal hernia will enter the deep inguinal ring. That means it is lateral to the inferior epigastric vessels. It will enter the spermatic cord or the inguinal canal. It will pass through the superficial inguinal ring, and it is more likely to go into the scrotum. Okay, that is regarding the indirect or the indirect inguinal hernia. Okay, so sometimes you might get some questions with images also like this. A patient presenting to emergency department with worsening abdomen distension and visible abdominal veins. Patient has chronic alcohol abuse and has got now fatigability jaundice. Which of the following vessels is involved? Is it the gastric vein, the epigastric vein, the vena cava, or the mesenteric vein? Okay, so obviously, when you look at this patient, the patient has got dilated veins spread across the entire abdomen. So the obstruction is inside the, you can call this as something like the caput medusae. Okay, this is the typical picture of the portal hypertension with radiating vessels away from the umbilicus. Okay, so this is the, you have the increased pressure in the portal venous system. So that leads to engorged veins around the umbilicus. So there will be a shunting between the paraumbilical vein and the superior and inferior epigastric veins. So all the blood which is thrown back by the portal system will be visible through the abdominal veins, that is the paraumbilical veins and the inferior and the superior epigastric veins. A patient presents with a large wound on the leg that has been left to heal naturally without surgical closure. This type of healing is described as, is it primary, secondary, tertiary, or delayed primary? Okay, so this is the example of a secondary intention healing. See, supposing you do a thyroidectomy and you close the wound, that is called as the primary intention healing. Supposing you don't close the wound, that is what is called as the secondary intention healing. So, because we are leaving this wound open for healing, this is called as the uh, secondary intention. So this is with this slide we will stop for today. That is a 50 years old patient coming to the OPD about a whitish discoloration on the mouth. So you can see on the inner aspect of the cheek there is a whitish lesion. There is a whitish plaque-like lesion which could not be rubbed off. What is the most likely diagnosis? Is it leukoplakia, erythroplakia, speckled leukoplakia, or chronic hyperplastic candidiasis? So this is the typical appearance of a leukoplakia. You have a whitish lesion, it cannot be rubbed off. Okay, it's a whitish. It cannot be characterized clinically or pathologically as any other disease. It is a pre-malignant lesion usually seen in patients who are pan chewers, who are smokers. Due to the chronic inflammation of the mucosa, the patient gets a whitish patch. That biopsy is mandatory, and then you might even excise it. But the main treatment is to stop uh, the risk factor. That is, if the patient is smoking, he has to be advised to smoke the smoking, or if it is a pan chewing, that whatever, that has to be stopped so that the patient does not progress on to frank malignancy. Okay, so I think we'll stop for today. We have covered most of the topics that I intended to. The rest for the next week, I mean, for the next session, when we will discuss mostly about scenarios. So, if you have any doubts, please feel free to discuss now, or you can put them in the chat. I will stop sharing now. Yes. Yes. Any doubts? Sapna, are you there? Sapna? I'm not. Yes. Sapna is not there. We will wait for a couple of minutes more. So if you have any feedbacks, anything, any doubts, or any specific topics you want to discuss for the next session, also you can put up in the chat box. any queries regarding the questions which we discussed today, or you want to discuss the next session in a different manner also, you are free to voice that also. No comments?
So thank you.
Okay, so if there are no more comments, I think the host has told the thank you also. So then I think we can wind up. Okay, so you keep on preparing well. Okay, so you can continue with your preparations, and not just in the chat box. If you want to give any feedback regarding the next session, you can inform the admin people. Okay, Dr. Sapna or any of the hosts from the IMAKSB, you can inform them. I will try to incorporate the suggestions in the next session. Okay. Yes, so have a nice night and the subsequent days also. Okay, so thank you everyone for listening. Good night. Bye.